I apologise if your questions haven't been answered. We have had quite a few come through, but just due to time, we will move on to our third speaker. So I'd like to bring to the microphone Kristin Young. Thanks, Kristin.
Hi. Can you hear me all right?
Yes.
Beautiful. So my name is Kristin Young. I was diagnosed with ovarian cancer stage 3C in 2009. So you can see that's 10.5 years since my diagnosis, and 7.5 of those years I've been on clinical trials. So that's given me a chance to see the changes and developments in both research and in the new treatments, because of course the new treatments are born out of the research that's done. So I've been actively part of that era where the new treatments have started to spread out into the community from what originally being research studies and now being something that many more people can access and almost becoming standard of care. Also, I've always been interested in research as a way of solving problems. So I guess I was naturally drawn to being interested in clinical trials. So I had the standard sort of high-grade serous ovarian cancer, and I had the fairly typical initial treatment of surgery followed by 6 cycles of carboplatin chemotherapy. So I had a good long remission after my first treatment of 4.5 years, and I'll talk a bit more about that when I tell you about my first clinical trial. But as you know, the chance of experiencing a recurrence is pretty significant, and at 2014 that did happen to me. I decided to have a second surgery, and that's me on the left, sort of coming out of my second surgery and then in my chemo for my retreatment. So that's the last chemo I've had, because I have been on a clinical trial receiving a PARP inhibitor ever since then. So that's a very, very interesting story, which I'll tell you more about now. So when I was first going through treatment, it was really early on that my oncologist said, and when we finish your chemo, we'll look at a clinical trial. And of course, my ears pricked straight up because I'm kind of interested in research. And I think also that was a sense that I was going to be able to do something rather than nothing after my chemotherapy ended. So I was so keen that I found out all the details, and I went and approached the trial centre way before I was even going to be ready to do it. But I was so looking forward to it. And the other reason that motivated me then too was that I knew that when people finish chemotherapy, they often feel a bit lost. And the doctors happily send them away and say, congratulations, you finished your treatment, now get on with your life. And on the patient side, it's, oh my God, what am I going to do? So I figured if I was on a clinical trial, I would have to have a lot more attention and people fussing over me and taking note of how I was going. So I really, that was a big motivation for me to go on the trial. The drug I did go on was anti-angiogenesis drug. It never did come to market. It did okay on the trial, but it just wasn't cost effective for the manufacturer apparently to bring it onto the market in Australia. And to this day, I don't know whether I was on the placebo or not. And interestingly, for that trial, I don't really much care, because the main reason I was on that drug was so I could get the attention, as I always say. So whether that contributed to my first long remission, I don't know. I will probably never know, but it may have. But then with my relapse, obviously things are different, and as anyone who's been through this knows, when you have recurrent ovarian cancer, your outlook changes, and you start to become highly motivated to do anything it takes, because cure then is not really one of the serious options. So I knew about PARP inhibitors already. I had already been identified as BRCA2. The PARP inhibitors weren't available for people who were not recurrent at first, so that wasn't an option for me. I had to wait to recur till I could get that PARP inhibitor. Things have changed now, and you can get it first line. But I desperately wanted that drug, and I so wanted to be on it. So after my second surgery, I was very ill with a complication called chylosociety, and my chemo was delayed. The problem with this is that the Solo 2 trial that I wanted to get on for the PARP inhibitor, because at this stage it wasn't available on the PBS, was going to close on a certain date. And I had to get through 4 cycles of chemotherapy by a certain date, or else I would miss out on the PARP inhibitor, potentially, perhaps not forever, but I worried that if I didn't get on it, it could be life and death for me. So it was a bit of this race against time, and because I was so ill, my hemoglobin levels were too low to qualify for the trial. So just trying to get well enough. And then I remember that I just had to get those hemoglobin levels. So the night before my test, I dehydrated myself and ate a great big red juicy steak to make sure, and I got over by one point and qualified for the trial and started on the PARP inhibitor the following week. So that's 5.5 years. So really that's my life. And I really feel like I belong to something, I feel a bit, I like the feeling of being a bit special. I mean, AstraZeneca like me, because I'm doing well. There are some downsides for me. It's when you're on a clinical trial, you can't fiddle around with the dose, perhaps the way you would if you were getting it normally prescribed to you. Because if you dose reduce on a clinical trial, then you've got to stay on that low dose. You can't go back. So if you're having problems with side effects, it can be difficult to manage with dose reduction. You can only have short breaks off drug. So if you're struggling with side effects, sometimes a clinical trial doesn't give you flexibility to manage side effects. Another funny thing psychologically was a bit of survivor guilt too, because I was doing really well on the trial and people in my support community, perhaps some were not doing so well, and I used to feel guilty that why have I been lucky to get this and other people haven't been able to have access to it. But I then came to see that people could see that if I was able to be a symbol of hope, that at least somebody was getting a good new drug, even if they couldn't, that somebody was, and therefore there was some reason for optimism. And that optimism has turned out to be well placed because more and more and more people are getting access to these treatments. But for me, the worst part of the side effects, because I was on a placebo trial, was I couldn't really prove that they were due to the drug. So I used to worry about this. Is the fatigue, is the lack of concentration, is this all in my head? Am I giving myself this because I'm thinking I've got those problems? Because it might be on the placebo, it might be not be really side effects at all. So it would make me a little bit anxious, and I'd go into prof and say, look, I worry because people don't believe that I really am fatigued. Because if I'm on the placebo, then I've got no reason to be fatigued. So I'm obviously making myself fatigued. So that's a bit sort of weird and psychological, but it was definitely a problem for me. But once I got to about the 3-year mark, it was pretty obvious that I must have actually really been on the PARP. Just because of the survival pattern I was exhibiting, I began to feel better about it. So my life is around these little fellas, and so all on a timetable. So what would I say to some other people who are thinking about clinical trials? The first thing I'd say is for some of the drugs that people are looking at now, really trials are a way to get access to drugs that may not otherwise be available. I mean, drugs like PARP inhibitors are available on the PBS for a lot of people. But there may be people who think or would have reason to believe that might be wanting to have those drugs, but they're not eligible for some reason or other to get them on the PBS. So maybe their only way to access these drugs is through a trial. So trials for many people in our ovarian cancer community are about access to drugs, not really about research. They're about how to get drugs that are otherwise too expensive to buy. But these days, as Prof was saying, there's so many trials now. There's, there's all interesting combination drugs. There's, earlier phase trials. And another thing there's a lot more of is compassionate access to drugs as well. The trick is always finding out about trials. It's not that hard to find out about the major trials, but there's so many little ones now, and no one oncologist, perhaps other than Professor Friedlander, can retain all of that knowledge in their heads, I don't think. So finding out about what some of the more smaller or unusual trials, you really have to, perhaps go and see a couple of different doctors and find out some more about it. Eligibility is a rocky road because you have to be eligible for a trial, because for it to be valid research, you have to study people that you can make realistic comparisons between the groups. So there are a lot of people who won't be eligible to join a trial. And being rejected for a trial can be quite upsetting and make you feel like you've been discarded or thrown away, or feel like you're missing out on something that other people have access to. And I think for a lot of people that can be really tough, especially if by their background they may have not had any reason to learn about how research is conducted and why trials are designed that way. So it can be an emotional roller coaster going through the eligibility process, because you can get quite a long way into the eligibility process and then still be rejected sometime down the track. So then the biggest question for most people is risk versus benefits. When you're in a recurrent ovarian cancer state of mind, you're pretty much, many of us are really going to want to try just about anything that will help. But as Prof said, these things come with side effects. And in some individuals, they can't tolerate these drugs at all. And there's also more subtle harms as well, is that, like for me, I've been on this for so long that I will never, in fact, return to normal. Like some people say, well, you finish your treatment, you'll eventually get better, you'll eventually return to a normal state. But for me, I'm on this long term. This is my normal for an open-ended period, who knows how long. I am a super responder now. I'm in that small cohort Prof was talking about that had the extended response, and we have no idea what the future holds. Once you're sort of 4 and 5 years into it, you start to think, is it worth it? Is it worth still putting up with this? Am I really getting, still getting a benefit? What if underneath all this I've actually been cured and I don't even need to be on this anymore? This, however, is a question that for which there isn't an answer. But having said all that about side effects, I would say that if you're faced with a chance to go on a clinical trial or one of these new treatments, and I see this on the internet forums, people expressing a lot of worries about, I don't know how I'll cope with the side effects of the PARP inhibitor. My first reaction when I read that is say, well, just think about, what's the alternative? And for me, I'm going to keep putting up with it because the alternative is perhaps not so palatable. And I'm not too worried about this. People say, I don't want to be in a clinical trial because I don't want to be treated like a guinea pig. I happen to like guinea pigs, and I did breed them for a while. This is a Shiba mini yak, and I had one of these. They're very nice. So I actually don't think there would be a bad thing to be treated like a guinea pig. I was very nice to mine. And just if people want to be part of the research community, but clinical trials are not available for them, there are other ways to participate in research, find out things and make a difference. And we're talking about the Innovate Trial. It wasn't a trial, sorry, the Innovate study. I won't know much about it myself, but that's looking at people's characteristics of people's tumours. There was overseas, there have been studies on secondary surgeries. I had a second surgery. I would have loved there to be clinical trial data about whether it was worth it. There wasn't at that time. There's clinical trials about exercise. There's clinical trials about side effects, quality of life. There's a whole lot of ways to participate in research if you don't participate, in a clinical trial. So research isn't just about drugs. So I'm sort of use my blessing of having an extra lengthened life to try and do a bit of advocacy. And this is Ovarian Cancer Awareness Month. But I don't know, obviously, what the future holds. Prof just shrugs when I say what's next. He doesn't know. No one knows. We are breaking new ground. But I'm very pleased to have been part of that revolution and, to be at the beginning of that and to see all the people that are coming on behind now and benefiting from the new treatments and all the creative new trials and new research. So that's me.
Thank you so much, Kristin, for sharing, your experience, your journey since being diagnosed, and your experience of being on clinical trials. There have been a couple of questions posted. One is, how difficult was it being on the trial and knowing that you could have been part of the control group and not actually receiving the drug? You touched on it a little bit, but with the last trial especially, how difficult was that?
With maintenance trials, it's not one thing that's helpful to remind oneself is that if you're on the placebo, then you're just like anybody else who's not doing anything anyway. So really, you're not worse off than anyone else. The only thing you feel is, am I going to all this trouble for nothing? But the other thing is that there is evidence that being on a clinical trial, even on the placebo, does give benefits anyway. I don't know that it can show benefits in survival necessarily, but a heap of other benefits for people just because they are within a clinical trial. So I also, because I knew that, I also took the view that what does it really matter if I'm on the placebo? I'm getting all these other benefits. So yeah, that was my thought on it. It's probably still worth doing.
That's a great attitude to have. Very, very optimistic. One other question: what side effects have you suffered, especially the long-term side effects? What have you experienced?
Yeah, well, just a quick point here. I just got unblinded from this trial 3 weeks ago. Okay, so I have just literally found out after 5.5 years that I have been on the active agent all along. I haven't been on the placebo. That's new news for me, and I'm just coming to terms with that. That's great, because that means all those side effects I was suffering were actually real and not in my head, and I wasn't inducing them by, poor lifestyle or whatever. Though the downside is that now I feel like I'm on my own and I'm, not going to be looked after anymore. That's a false belief, but it's still an anxiety that I have. The main side effect for me is it's like any chemo, but about 10% of how bad you feel on normal chemo, just slightly out of it, like fatigued, a bit queasy, just like foggy in the head. I get some mouth sores sometimes. I get a bit dizzy. I'm lucky that I don't have the blood test problems that a lot of people have with this, the low hemoglobin and stuff. I'm lucky like that I don't have that. I've never had anything complex with the side effects, but it's like being on chemo, but not as bad, because I periodically have breaks. When I have breaks, I feel like I get a big slab of myself back. Not my old self, but a lump of it comes back, and then go back on the drug, goes away again. But it's worth it, I think.
Well, thank you so much, Kristin. We really appreciate you giving up your time and just being so open and honest, in sharing your experiences. So I know everyone on the webinar will appreciate it very much.
Thank you.
So I do realise we have gone over time. I do apologise, but so much valuable information that we've heard tonight. So once again, I'd like to say a big thank you to our presenters, Professor Michael Friedlander, Dr. Yolan Antle, and Kristin Young, for giving up your time. And, you know, we know how busy you are, especially at the moment with all that's going on. So we're ever so grateful. Thank you to everyone who has joined us this evening. We really hope that you found it valuable. The recording of this webinar will be posted on the OCA website over the coming weeks, and you will also receive a link to the recording in the next week or so. In a moment, you'll be directed to an evaluation form. If you could please just take a moment to fill that in, because that really helps us to receive your feedback and helps us to plan for future webinars. If you have any other questions, please don't hesitate to contact our information and support line on 1300 664 330. This is obviously a very challenging time for everyone, and we know that many of you will need that extra support at the moment, so please don't hesitate to give us a call. Thank you again, everyone. We hope to see you for our next webinar, which should be in June. For now, please stay safe, stay well, and enjoy your evening.